Just go forward, backwards. If you accidentally hit one of these buttons, it'll probably make the screen black, but if you can begin, go back. Okay. Just do the arrows.
Yeah, let's focus on the arrows.
Yes.
That's good deal. Thank you.
Of course.
All right, Kenny, are we ready to start?
Yes, sir.
All right.
Thank you for your patience.
Hi, guys. Welcome to June Mi6 training. And thank you to Travis for getting us back on track with the educational components and all that good stuff. First thing, we'll try to do discussions and then a little bit of case study, and then we'll jump into the lecture, which is iEmergency. So the first thing to kind of cover ground on, since we're all in the room, we also have Sobering Center, not to put you on the spot. But thank you for coming. But we'd like to kind of discuss how things have been coordinated through the Sobering Center and if it has been running smoothly contacting CHIP for some of this stuff to go through providers. The reason we're bringing this up is if we're contacting CHIP directly from Sobering Center, it adds a new element between the providers and the patient. The big thing for us is that we're not developing relationships with these patients or not contacting these patients, and we're still expected to prescribe medications. It becomes a little bit dangerous for us because doing that is actually something you're not supposed to do. It's against the protocol for a medical license. But the goal is to try to identify where we can come up with some efficiencies for you guys on scene, for the providers out in the field, and kind of closing that gap between provider and patient. Okay, we're prescribing narcotics. We're looking up the prescription drug monitoring program to make sure they're not over prescribed and things like that. So the big question is for you guys, are you guys finding that it's pretty efficient to go through CHP versus just contacting C4, then the provider? Because I know a lot of you guys go down to the Sobering Center and do assessments. And are you guys finding that's better for you guys to keep track of these folks or anything like that?
Are you asking Sobering Centers?
I'm asking all of you. Yeah.
I think the majority of the people who are going down there are the CHIP responders. Not
Right.
so much the case managers.
Right.
You have case managers living right now.
Okay. So,
Right.
Yes.
so most of the CHIP responders are the only ones going down there. Because I remember I saw a couple of you guys at some point. I know you guys get called down there every now and again.
It's usually
Okay.
it's usually the chip responders like us, myself, Adam, and Lo.
Okay.
I handle most of those that come down there. The idea was that we would come do with the alcohol program and all the things. Is one of us would do that. They would call C4, and then one of us would go out there and make contact. And the idea, and a lot of times I feel like someone, I think we had this conversation the other day about like someone just got lost in the sense that like a lot of times they're just going out there going, I'm just here for the meds. What am I here for? And they're not actually connecting with the patient, kind of figuring out like what else can we do to support them and all that kind of stuff. It's the true spirit of the program, of the alcohol programs. That kind of answer.
That's a component of it. Really, I think, and feel free to chime in. You guys at one point were calling C4 directly, and then
We were still to call C4 directly. We were calling CHIP directly, and that started to get really confusing. So then we
Right.
were directed to call C4.
Okay.
And C4 was to then connect with CHIP, and then they would, either C4 would call us back and let us know what CHIP were and what time they would come, or CHIP would just call us and be like, hey, I'm the one on the case and coming.
And the reason we did that was because they have so much turnover over there. It started to get really, really muddy. And so you'd have like the night crew who'd only been there for a little while who told somebody else like, hey, I know that I call this response and it's the chipper phone or whatever, because they'll call me back and they'll do whatever. And just going through other people, we weren't tracking anything. And I know that Travis and I had this conversation the other day too, that if they call C4 and C4 connects straight to you guys and you guys don't feel like you need us to go there,
Mhm.
I don't have a problem with that. Like,
Okay.
If you guys get on the phone with them and you start looking at that saying, hey, kind of feel like one of our people should go out there and then send us back out there. Or if you guys are really far away and nobody can make contact with them, then let's do that. But they can, I don't have any issue with them going directly through you guys as long as it goes through C4 first.
Okay. I guess, I mean, this would obviously apply a little more than chip responders, but okay, as long as we're funneling through C4, we don't mind going down there directly if we're close and we're free. I think, again, the big issue for us is developing that relationship. So if a chip responder is there, it's not just a simple text to C4 like, hey, put in a script for this guy. We probably need a telehealth, and we probably need to actually meet face-to-face through Pulsera. Okay, that's the big issue. And I know we've been doing this for a while and just throwing meds out there, but it's a dangerous precedent because some of the stuff is not being accounted for. Some of the information is missing. The charts, there's a lot of information that could be added that is not there to cover our rear ends. So it's a matter of just trying to, touch all the bases and coordinate with everybody, make sure we're doing the right thing for that patient. Okay,
Can I catch up with you later to hear what information is missing so I can give it to them?
absolutely, yeah. All right,
And I know on the, like, say chipper, but I think they're calling the CDO line, 'cause I still get phone calls, even when C4 is up to,
Are we calling the wrong number?
Yeah, that's what's happening, because they should be going, it should not be going to the CDO, it should be going to C4, because that stuff should be tracked through C4. That was kind of the understanding. And that came from Brandon as well. Like Brandon and I sat down and had that conversation, and that was when it was decided that they would get nothing would go through C4.
Yeah.
Just because calling random numbers like that got really confusing, because at one point my number was up there, Amber's number was up there, the ship responders number, it was just numbers tagged to the phone, and they just kind of picked whoever they knew and wanted to call.
That kind of sets y'all up for failure.
Yeah. And it's
Also,
been
there's
a
a lot
lot
of-
smoother now, we're just to call C4, so I'm hoping that we have the right number for C4. Maybe there might be some medics that are a different number, I don't know, I can look
I'll
into
make
that.
sure, I'll give you both
But
numbers.
make sure you give me, yeah.
Yeah, I'll give you both numbers, so you kind of make sure they clean up the only C4.
Yeah.
I think that's a compliment though, so far.
The only time that wouldn't work is if you really needed something in the middle of the night.
We'd call med control probably, right?
Yep.
And correct me if I'm wrong, but is it a lot of, like the medics in the field, like on the trucks calling? The CDO line, and then calling sobering center and saying like, like they don't know the process as well.
I don't get too many, I get medics in the field calling the CDO, but not necessarily for the sobering center. I've only,
Okay.
I can only had that happen once and it was an issue. So it's more of, are you Jenna?
I'm Kimberly, Jim's no longer with us.
Okay.
She's not dead, she's
Okay.
I'm Kimberly. It's nice to meet you in person. We talk on the phone a lot.
That's, on the bigger, better things in Dallas, so,
Okay.
yeah. But, yeah, and like Zach said, we have a lot of people turning around. But,
We just want to make sure you guys are getting what you need. I think that's where, and then that we're closing the loop both on the communication and.
and just like that worked out, right? Like figuring out, making sure we have the singular phone number, there's one direct line of contact. Those are the issues. And if we can make it more efficient, that's the best way to do it. One of the problems that we have too is that, correct me if I'm wrong, you guys can use Apricot for patients you guys are making contact with at the sobering center for some of your chip responders, right? Yeah, we don't have access to that, right? So when it comes to that information you talk about missing, well, that's part of it is we don't have access to Apricot. We're not looking at that, right? So we don't have a lot of it. We have what we hear on the phone, and a lot of that is third, we're basically playing the telephone game, right? It goes to C4, comes to us, we're just like, okay, yes, that's right. And then we send it up. So those are the things that we're trying to fix, okay? Question.
Do you have a process you would like them to follow?
Keep doing what you're doing, contact C4. The big thing, if you have a provider on scene and they need medications, let's try to get a Pulsera done.
Okay.
With a provider.
And it can be, it could be through the sobering center. Doesn't have to be.
It doesn't have to be a chip
CHP.
responder. It can absolutely be them on scene.
We
Yes.
might need to have somebody go over and kind of show them how to use this, the Pulsera, because they have access to it, but I don't think anybody's really comfortable with it over there.
Brandon's working with someone and they came over last Tuesday to talk to him about Pulsera, and I downloaded the Pulsera app on our serving center cell phones. And so he said he was gonna be getting with me soon on that. He's working with someone.
It's in
There wasn't
progress.
the demos.
So for the interim, it will be the chippers. They need to use Pulsara when they are there, rather than doing the C4 to online medical control consult. And I'll catch up with you later about the documentation information. Once the sobering center has Pulsara, are we still intending to send the chippers on these calls, or will it be just the sobering center call?
I would still like one of us to get there if possible, or if those guys aren't able to get on scene, I'd like somebody to get there so that people with eyeballs on somebody kind of evaluating if there's any more to it.
Okay.
Besides just calling in for delivery.
Is there a way that we can train the sobering center so we don't have to have that
Yes.
extra? Because I think one of the reasons we are bringing this up is just the same thing you and I talked. We're bringing somebody else that has had the exact same assessment that every time I've been there, it's been within you know, a CWA within 2 or 3.
Yeah.
It's exactly the same thing. They find the same thing. The chip responder goes and they find the same thing. And then I'm brought in, you know, for the solution, temporary solution. We do not solve these. Y'all solve these. Let's be very, very clear there. But, you know, half the reason I want to do this is I don't want to waste, you know, anybody else's time. I don't. And, you know, the idea was that we were going to provide services, but y'all have, you already have all the services. We've never once connected somebody to alcohol rehab that y'all weren't already working with. You know, if they're there, you are going to be the ones to do it. So why come in and reinvent that wheel is kind of the thing. So I don't, unless we've identified like a clinical concern where we're finding something that the sobering center is not able to find, I don't know if it's worth the squeeze if all you need is Librium to send a chip responder over just to do paperwork.
Yeah.
That's my take, and that's, you know, the same thing. I think
idea
that there's other places that they could be better, you know, utilized within the system.
The idea
It's
was
not allowed to the phone, correct? So get like the programs they need.
we'd still like to get there, but
Yeah, so with buprenorphine is very, very different.
Yeah.
You know, we have a like well-oiled machine that is the stuff, and we do the connection, we do that, but with alcohol, y'all connect almost every.
and we originally, the idea was that we would carry the to an all.
And I think that's a whole different, I think that's a 9-day different conversation.
And we haven't gotten there yet,
Yep.
so we were doing this with the plan of
Yeah.
that's where we're gonna land, and now that it's still gonna take a while for us to get there.
I bet we would have this conversation again next
Can I
year.
catch software?
You know? Yeah, so
So yeah, I'm good with that. I don't see any reason why.
if we start hearing Librium, very different,
Exactly.
very
The
different.
question is, do we need to carry it?
I would rather get phenobarbital injections in my opinion, so.
I see your Librium, I raised your phenobarbital.
ICU, but the thing is, it has like,
They have to be monitored for
which the sobering center is monitored.
that. They have like.
Oh, yeah. They have to be monitored for a period of time. It has to be either ICU or I can give it the ER ICU.
Yeah, Sovereign Center has problems trying to keep people in,
Yes.
right? If they want to leave, they go back.
It's also some kind of start having that conversation, like, okay, I think we can probably.
Yeah.
Remove somebody from that, make sure that they're using Pulsera, and they can do all that stuff.
I never actually thought about, you know, I mean, it's cheap and easy and safe and really good data.
All right, so that's why we talk about this stuff, right? Kind of coordinating.
We can close that loop back. So what's,
So right now, nothing's gonna change as far as them contacting C4.
okay,
They're gonna go directly through C4, and if they need to send out a chip responder, right now, because they don't have Pulsera, like education or setup or whatever, they're working on it. It's still gonna be a chip responder to go, unless one of us is nearby and available, we'll go.
so a responder, so it could be a PA, it could be a PRU, it could be a case manager. It
Yes.
could be a chip responder,
Yes.
someone in integrated services.
Correct.
Okay,
Yes.
and who makes that decision?
Medcom chip 7.
Go ahead, Chip 7.
That's me.
All right.
And
Service.
if they call the CDO because C4 is not up, C4 didn't answer, then
That's a great question. So you can still send one of your folks, as long as the Pulsera is created on scene. That's our big issue. We need that contact, because that covers us all.
And that is a doc or PA, like physicians should be using it just the same if we're doing narcotics. Legally, you can do it on the phone, but it's very, very, very gray area.
Once they have access to Pulsara overnight, are we anticipating still sending somebody to the scene? Or
No,
will that be?
No, if they have that access and they can talk with the provider directly, no more middlemen, right? That's the goal.
Cool.
We shouldn't be doing a whole lot of that on scene because they can't even get the Librium.
In the
So,
middle of the night, right?
you
I've
know,
gotten it from, like, there are a couple 24-hour pharmacies.
there are, but I mean, we would have to make sure that like,
We also said that we would not do it outside of the C4 hours.
That's right. Okay,
I
thank you.
think that's very reasonable.
Yeah.
For
so that's-
Librium, like if they're that bad at 2 a.m,
Then you go back to the.
send it to the ER.
Say that.
And Travis and Chris, from the
Yeah.
C4 perspective, be sure to remind the sobering center that even though they find it easier to go to the 7th Street HEB, Hancock Center is the bigger pharmacy and routinely has Librium where the 7th Street can run out of it. So
Okay.
Thank you, Doug.
use Hancock Center.
It's like the voice of God.
All right. Any final comments or questions on that?
You got any questions?
Yes,
But
There's a chat from Pee-wee noting that frequently they get calls from the sobering center around the 8 a.m. mark. That's more of like an operational thing for us, like how that's aligned with how many actual field providers we have, since we have that 10 a.m. shift change.
gotcha. So is that something that we're talking about waiting until shift change complete? Is that the question? Or is it just, hey, this is a comment, we've got 8 o'clock, we keep getting a lot of calls. That's opening business hours for y'all, right? It's like, it's basically, hey, it's 8 o'clock, we had this stuff overnight, this is what we need to take care of, right? So they're starting their day.
So our shift change is right at 7, so it's like night shift is like trying to carry the patient out till the morning until we can get, so they don't have to send them to the ER. So right when we get on, that's when it's like, okay, we gotta start calling. They're at that point where it might be going to the ER if we don't have.
And then
So-
Gotcha.
we have
Yeah, that
ship responders are in the 22nd hour of their 24-hour shift at 8 a.m.
So it's brutal to do that. So is there, maybe we can coordinate through C4. If it's something that's gonna be immediate need, we'll still have to send a responder. If you guys can delay it,
Integrated service person.
but, great, sorry.
It could be.
It could be anybody from,
Eventually.
could be anybody from MIH.
Father.
Yeah.
Terminology matters, correct?
Yeah.
Yes.
So, because there's,
Yeah,
Yeah.
so not just your, yeah, anybody from MIH, but if it's not a critical need within the next couple hours, maybe we can postpone until
10
the shift
o'clock.
change.
Yeah.
But either way,
Call at 8 a.m.
I was gonna say, either way, contact C4.
You need help.
Yes.
Yes, always call C4. If you need to call at 8, that's fine. Keep those calls going. We'll get with C4. Doug, if you can just make a note of that. If it's not a critical need, maybe we can send a responder who's already done crew change, or one of the PAs who they typically do earlier crew change.
Or a PRU or a.
Or
case manager
PRU
or available.
if they're on.
Let's look at the NDC and.
Any of us to come in a little bit early.
Come on, I'll go.
Okay, awesome.
No reason why I couldn't do that.
All right. So I'm looking at the notes they're sending here. It's a critical need. Okay. All right. So let's get started on some case review here. We're going to talk about a case of lower back pain. This is one of the cases that we go on pretty frequently in our system. And it's one of the top 5 complaints in the ER. So it's something that we're definitely going to come in contact with. We tend to discount lower back pains. So I'm going to give you a case and we'll kind of work through it. We've got a 27-year-old male, Hispanic. He's in his apartment. He calls you for a 2-day history of lower back pain. Once you walk in, it's kind of dimly lit. He looks uncomfortable, but he tracks you as you walk in. He just says, yeah, I don't know, my back's been hurting for a couple of days. I just need some help. I'm having trouble like moving around. What are the big questions that you guys want to start off with for this guy?
Any trauma?
Any trauma? No.
What they feel like, what is it, what does the pain feel like?
Okay, so as we're discussing the pain, he's like, I don't know, it just feels kind of like a dull ache. Anytime I move, it hurts worse. I couldn't really sleep over the last 2 nights, and that's kind of why I'm calling. I've got a lot of discomfort. I've tried taking ibuprofen. It's really not helping a whole lot. Other than that, I can still walk, but I'm just having to walk really slow.
What does he look like?
What does he look like? Okay, so in general, he doesn't look like a super sick person. He just looks like your average 27-year-old who looks uncomfortable. Okay, he's not sweating, he's not pale, skin signs are all normal. He's alert and oriented. He's tracking all movements. He's able to follow all commands. And again, all extremities, he's able to walk and move without issue.
I'd ask him like, in the past, when's the last time you had a surgery? Have you had a surgery?
Never had surgery. 27-year-old, been healthy up until this point.
Has this ever happened
No
before?
medical history.
Never happened before. Medical history, none.
Any neurological.
How's his and then
Bell bladder.
movements?
Great. All right. So we got a couple. All right. So we'll start with any radiculopathy, right? So the big thing is we're always looking for cauda equina, right? That's our big thing. Like that's our big flag. What does cauda equina start with? You might know.
Saddle numbness?
So everybody thinks it's like the subtle numbness. That really is the first part of that. It is one of the earlier onset symptoms, but there's a couple others that usually you have to clue into before that occurs.
bladder retention.
Bladder retention is one of the big ones. What's even before that for most patients?
Radiculopathy.
Radiculopathy, and which is just nerve pain, right? So sciatica is the most No radiculopathy, right? Sciatica. So
Cervical radiculopathy.
what's that?
I have cervical radiculopathy.
There you go. Yeah, so nerve pain, right? So
It doesn't sound real.
it doesn't. It's a real word. So with that, yes, this guy, he says, I don't know, maybe I had an episode where it was kind of shooting down my leg, but I don't really feel that right now. He doesn't have any urinary retention. He doesn't have any urinary incontinence and no saddle anesthesia. Now what? We can't rule out
What,
cataquina, but that's a good thing to look for immediately. So it's not as high up on our.
what was the onset like? Was it sudden? Was there any specific pain involved? Like,
It was slow onset, and he says, I don't know, I got home from work, kind of sore, and I don't know, over the last couple of days, it just feels a little more sore.
So if we're moving away from neurological, I think more vascular at this point, maybe.
Okay.
So is he having any like radiation from the pain?
Great
Any
question.
testicular pain?
Good.
Dennis,
you might want to turn
your
your
video
camera
is
off.
on.
Hi, Dennis. Hi, Dennis Chen. So great question. All right, so let's start talking about if there's any vascular condition. And we're talking about like AAAs and things like that, right? So in this case, there's nothing obvious. He hasn't been feeling any significant abdominal pain. He hasn't had any GI distress. He hasn't had like any radiation pain, like towards abdomen, chest, anything like that. Just other than that, he just feels uncomfortable.
What's his food and alcohol intake like?
Great question. All right. So food he's been able to eat. He's had a little bit of a decreased appetite over the past, I don't know, let's say a couple weeks to a month. He's just like, I don't know. I usually, I used to eat a ton of food, and now I snack here and there. As far as fluid intake, he's good amount of fluid intake. He's, the adult average male pees about 4 to 10 times a day.
Mhm.
He's well within that range. Okay, so he's hydrated, he's fed.
Alcohol?
Alcohol, sorry, I didn't answer that. Yes, no alcohol. He says every now and again I do, but I haven't had any like in the past month.
Family history.
Great, family history. So he knows that his dad died young of cancer, doesn't know what kind. And he knows that his mom has a history of high blood pressure. She's still alive, she's on medication for it. Where do we go from here?
Is there are you able to identify any causative event or either make it better or worse?
Let's talk about what he does for work. All right, so he said he came home from work, he's got some back pain. He installs stone countertops. So it's kind of easy to say like, okay, maybe it's a strain, right? He's moving stuff around, but he cuts and installs stone. So anything with that?
Does he wear respiratory protection when he cuts it?
Sometimes.
Okay. What kind of
You're on the
stone?
right track.
Yeah, what kind of stone? Is there any risk?
All types of stone.
Okay.
At risk for what? Anybody know?
Asbestos is kind of on my list, but I don't know if it's correct.
So asbestos, most places are getting away from that for like, kind of insulation, but you're on the right track. Now, why would this relate to back pain though? So back pain isn't just the back, right? So there's other things it can be, and she's on the right track. So the big thing I'm thinking of, there you go. Who got that? That's Amber. Good job, Amber. Yeah, so silica is the big one, right? Why is that important for this patient with back pain? He's a young guy. Why aren't we talking about like ankylosing spondylitis, which is like an arthritis that attacks young folks that have a family history? Why are we talking about his exposure at work?
What's more dangerous?
What is more dangerous? Absolutely, this is more dangerous. So this gentleman, he's a stone cutter. He's exposed to silica pretty frequently, and that leads to non-small cell carcinomas, right, in the lungs. Where does cancer like to spread? Bones, brain, liver, lungs, right? Bones. Now, one of the non-small, basically we call this adenocarcinoma, right? Adenocarcinomas like to spread to the spine. And in this case, you have a gentleman who has known exposures, doesn't really have a history, right? So he's not getting frequent evaluations. And here he is presenting to you with just dull, non-specific back pain. Okay, you guys ruled out the cataquina. You guys ruled out any, muscle strain. You guys ruled out vascular. But another big one we have to consider are the cancers. Okay. So in this case, and this isn't a real case, but this is something that's very, very common in the United States. There's over 200,000 cases of adenocarcinoma per year. Chances are you've already ran into these back pain patients, didn't even know it. It's a young guy, he works, he's picking up heavy stones, he's got back pain. What do we always do? Here's your ibuprofen, send him out the door, right? No, there's serious stuff that can be kind of drawn from this. And you guys picked up on one of the big ones, right? He's had a decrease in diet. One thing we didn't ask, just give a decrease in weight, right? So cancer patients, what do they tend to do? They tend to decline over time, right? So look for those trends, even in your back pain patients, right? What other issues in back pain can we try to evaluate for? So we talked about trauma, we talked about infection. Actually, we didn't really talk about infection, did we? Who have the highest risk for infections?
Autoimmune,
Autoimmune, absolutely. Who else?
HIV.
Definitely, autoimmune, yeah, with viral, what's that?
Cancer patients.
Cancer patients, absolutely. What about our IV drug user patients? We got a lot of those, right, that we come in contact with. What about the post-procedural patients? Maybe it's a pregnant patient that had an epidural or something like that. Very rare to have an epidural abscess like post-procedure. There's potential there, right? What else did we not discuss as far as red flag for back pain? Anything else? What about our older patients? Again, cancer is the big one, right? Multiple myelomas and things like that.
Any kind of referred pain, so like portal hypertension or mesenteric ischemia would be on the list, like a AAA would be on the list.
Absolutely. What's our age that we're usually looking for those big things like that?
65 plus or 50 plus.
It's even less, yeah. Usually 50 to 60, depending on who you ask or what you read. But those are the guys that are going to go in there, or girls, and they're going to get a CT.
You say 50's old?
Trust me, I'm right around the corner too. Yeah. All right. So any questions on just generalized non-specific back pain? That was really good. You guys teased it out. I mean, excellent. And Amber, good job. All right. So we're about the time. I'm going to take I guess about a minute break so you can reset. And then we'll start the recording again. So just take a minute.
Yeah, I will take a minute and run to the bathroom.
I might try this.
Do it. Do it. There's pie. There's custard pie if anybody wants it.
Zoning first.
Somebody wants to, Sarah. Yeah, or they can,